Well, yeah, thank you all for coming on the call. I think we're getting to a critical mass of folks. I'm sure a few people will continue to jump on as we go, but I think we're going to get started now. Yeah, my name is Mark Fine. I'm the Director of Municipal Collaboration at the Metropolitan Area Planning Council, and will be moderating this session. Thank you again for joining us for this webinar, Substance Use in Massachusetts, Path to Prevention and Recovery, which is the first of a series of 3 webinars that MAPC is hosting on this critical issue that continues to cause harm and create challenges for so many people in Greater Boston and across the Commonwealth and country. I want to first welcome our Executive Director of the Metropolitan Area Planning Council, Mark Drazen, to make some introductory remarks. Over to you, Mark.
Mark, thank you very much. And thanks to everyone who's participating this morning, both those who will be presenting and answering questions and those who are on the screen participating to learn and to join in the conversation. Prior to the pandemic, MAPC and especially our Metro Mayors Coalition was working very hard on issues of opioid use, substance use disorder, and related issues from a mental health perspective, from a public safety perspective, and from a planning perspective. Our efforts in this regard were somewhat interrupted. They never ceased completely, but they were somewhat interrupted by COVID and by the focus on working with our cities and towns to address that public health crisis. But in the last few months, I would say in the last year, we've really been interested in taking initial steps to get back into this work because of its tremendous importance, and especially because we have seen a link between the pandemic and related issues of substance use, overdose, and death during this very difficult, stressful, and challenging period of time in our country and indeed around the world. And so our leaders on both staff and board and in our municipal CEO coalitions like the Metro Mayors Coalition said, we have to get back to work on this. And we have to begin with some of the planning, some of the education, some of the conversation, but also some of the advocacy for appropriate funding and appropriate regulatory frameworks, especially on the state and local level, to address this serious issue. I feel that there are some municipalities, especially larger municipalities, that devote considerable effort to this issue. They have their own staff, they have their own plans and efforts and resources. But when you sort of get through the top 3 or 4, 6 or 10 largest communities, you have an equal level of desire by local officials to help address this issue because they all know circumstances and individual cases in their community. But they often don't have the knowledge, the resources, the connections, or certainly the staff to do so. And I feel like we are particularly aiming at helping those communities to know how to participate, what kind of services they can provide, how they can help to advocate on the state and federal levels, where they can achieve resources, and especially how they can cooperate across municipal lines, because 5 or 6 or 10 communities doing the same thing is always going to be more effective than one community doing it on its own. We at MAPC are really tremendously privileged to have a long-standing relationship that even predates my 20 years at MAPC with the family of former Newton Mayor Teddy Mann and his son and daughter, who have been actively engaged in working with us first through the annual Mann Award for Regional Leadership, and more recently on this issue. And we are really enormously privileged, again, I will say, to have Deb Mann-Schmill present here today to talk with us about some of her own personal and family issues and struggles regarding substance use disorder, and the foundation or the creation of the Becca Schmill Foundation, which is now a great ally in working on this field. I've had the pleasure, my wife and I, my children have had the pleasure of knowing Deb and her family because the kids went to school together for a few years. And I just can't say how much we feel indebted to her and her family for their work on this issue, and how glad we are to sort of participate in this struggle together. And so I'm going to turn it back over to Mark, and I know that shortly we're going to hear from Deb and then from our panelists. And I look forward to a great conversation and to the next upcoming 2 sessions, I think in February and March, and most importantly, to making progress in dealing with this terrible scourge in our society. Mark.
Yeah, thank you. Thank you, Mark, for that context. I think part of what drives our continued desire to engage on this issue is in part a desire to fight against complacency as well. I think with health crises like the opioid epidemic or even COVID, there's a tendency for people to begin to accept certain levels of misfortune and sickness and take it for granted that that will always be with us, especially in the abstract when it may not have impacted them directly. And frankly, we can't afford to do that. So it seems like a good time to build back some of the foundations and restart some of the work that we were doing on the pandemic before it happened, and evolve and expand our programming to meet what remains a serious crisis in our communities. And that is what this webinar series is looking to do some level setting about the state of the substance use crisis we are facing now, to help us collectively learn about and share new approaches for responding to this evolving crisis, and to consider what further solutions we need to pursue. But also, as Mark alluded to, another critical reason for us doing this is our relationship with Deborah Schmill, who has dedicated her time and passion to helping prevent others from suffering as she has from the loss of a loved one. And now I'll hand it over to Deborah to share her story. Thank you.
Thank you, Mark. Hello, everyone. Thank you all for being here. My name is Deb Schmill, and I'm honored to be here today to share my story. Before I do, I want to thank the entire MAPC staff for hosting this webinar in response to the opioid crisis, an issue that, as has been mentioned, is quite personal for me. Excuse me. On September 16th, I'm sorry, I'm having a choking issue here. On September 16th, 2020, at the age of 18, my daughter became a victim of this crisis. She had used social media to find a drug dealer to sell her cocaine. The drug she purchased happened to be laced with fentanyl. My daughter's tragic story actually started 3 years prior to her passing. At the age of 15, Becca and some friends of hers met a group of 18-year-old boys from another town on an online party chat. After a few weeks of chatting and sharing pictures, the girls accepted an invitation to meet the boys at one of their homes. Once there, the girls were immediately served alcohol in champagne glasses. Becca's drink was very likely drugged. When the rest of the group left the house to go for a walk, Becca could barely stand up and had to stay behind with one of the boys. Once alone, he raped her. After this incident, Becca met with a therapist, but talking about the rape was the last thing she wanted to do. Instead, she wanted to move on as if nothing had happened. She insisted that she would be fine, but she was not fine. There was an edge to her that had not existed before, and emotionally, she was spiraling downward. At that moment in time, when she was most vulnerable and most in need of support from her peers, a group of high school girls began cyberbullying her, further traumatizing her. We know that trauma physically changes the brain. This is particularly concerning for children as their brains are not yet fully developed. Childhood trauma is also strongly correlated with substance use disorder. Becca turned to drugs to ease her pain, deflect her self-blame, and fill the emptiness that she felt inside. When she was 17, she went to her first adolescent residential treatment facility. She was there for approximately 2 weeks and then released. She came home and within a month was using again. Relapse is common with substance use disorders. 2 or 3 weeks in treatment, which is a typical stay covered by insurance, is not nearly long enough. According to the National Institute on Drug Abuse, a minimum of 90 days in residential or outpatient treatment is needed, and treatment lasting significantly longer is recommended. In addition, after intensive treatment, a patient should be transitioned into less intensive continuing care. Unfortunately, this was a far cry from the experience we had with Becca. At 18, she started her journey into the adult residential treatment system, a system where a drug-dependent 18-year-old girl with a history of sexual assault is exposed to catcalls while in treatment with 60-year-old men who have been fighting addiction for decades. The final 8 months of her life were spent in and out of such treatment facilities. A few weeks in, release, a few months home, relapse. After each experience in treatment, Becca came home more jaded. She learned from other patients that she needed to hit rock bottom before she could dedicate herself to recovery. This meant living in the streets, begging and stealing for drugs, as they all had done, like a rite of passage that was set in stone. This was the single nugget of knowledge that she gleaned from residential treatment. Nothing about the need to carry Narcan or other harm reduction techniques, no information about the risk of fentanyl, and no appropriate outpatient plan. Late in August of 2020, Becca should have been on her way to the University of Richmond for her freshman year of college. Instead, she was in residential treatment again. When she was released, Stu and I picked her up, and instead of going home, we took her to a friend's house in Maine. We figured the change of scenery and distance from her drug dealers would be helpful. At that time, we were unaware that no matter where she was living, she could easily find drug dealers using social media apps. During the weekdays in Maine, it was just me, Becca, and a young woman Becca had met in treatment, whose parents refused to let her move back home. Stu came up on the weekends. We all agreed to the following plan. The 2 young women would get jobs, would regularly attend online support groups, and would be randomly drug tested. If drugs or alcohol were found, they would immediately go back to residential treatment. On September 15th, I found alcohol in their room, and the 2 dutifully agreed to return to treatment the next day. That very afternoon, they used Facebook to find a cocaine dealer. In the early morning hours of September 16, they used the cocaine, which happened to be laced with fentanyl. My sweet, loving, funny, beautiful daughter was gone. Her friend barely survived and spent the following year recovering physically and cognitively from her overdose. I often wonder how different our lives would be if Becca were born 10 years earlier, before smartphones became ubiquitous for teens. She would not have met the boy who raped her. The cyberbullying would not have occurred, and she would not have had 24/7 access to an illicit drug supply poisoned with synthetic opioids. After Becca's death, our family started a foundation whose mission is essentially to prevent what happened to Becca from happening to others. Through my work with the foundation, I have told Becca's story over and over, mostly to policymakers. With each telling, I'm painfully reminded of how seemingly preventable my daughter's death was. Over the last 2 decades, this country has seen a 400% increase in overdose deaths for people ages 15 to 24. Overdoses are killing more young Americans than COVID-19, and many of these deaths are preventable. Yet the urgency of the response to this crisis has yet to feel sufficient to me. That needs to change. It is imperative that we have a statewide, regionally coordinated response to this crisis. One where public health departments, insurance providers, pediatricians, public schools, police, social workers, treatment centers, policymakers, and family members are all on the same page. It is critical that we invest more in pediatric substance use research, in childhood trauma prevention and supports, harm reduction, and a continuum of care that is trauma-informed and age-appropriate. My family has withstood an unthinkable tragedy, the pain of which will be with each of us forever. But I have to remain hopeful. I find that hope in recent legislative attempts to rein in social media platforms. I find it in the increase in community conversations about mental health and substance use. I see hope in the dedication of so many caring healthcare professionals who are devoting time, energy, and resources to finding and implementing best practices. And I find it here in programs like this, sponsored by a highly respected agency in our Commonwealth, whose dedication to this project speaks volumes about its importance. There are too many Beccas out there to lose hope. We owe it to them to persevere, deliver the message, and find the answers, because they are our children. And I owe this to my beloved Becca as part of her enduring legacy. Thank you all for being here today, for listening, and for choosing to take part in this effort to fight the opioid crisis. Thank you.
Yeah, thank you, Deb, for sharing your story, which speaks to the challenges of our digitally enabled times, points clearly to continued gaps and problems with our system of treatment, and the easy access to drugs via social media and the threat from fentanyl-laced substances. Thank you for sharing all that. It's really important. And to build on that context, we have a great group of speakers now to each present. And I'll just introduce them really quickly and then hand it over to them. So Claire Hoffman is MAPC's wonderful public health planner, and she's going to review the latest data and trends related to the substance use crisis. Andy Robinson, who's a lead program coordinator in the Substance Misuse Prevention Unit within the Department of Public Health Bureau of Substance Addiction Services. He'll share current information and best practices from prevention programming across the Commonwealth. And Dr. Sarah Bagley, who's a primary care physician at Boston Medical Center and medical director of the Boston Medical Center's Center for Addiction Treatment for Adolescents and Young Adults who use substances. And she'll talk about the work she and her colleagues do to treat people with SUDS and perspectives on how we can help people through treatment and recovery. If time permits, after they're done, we'll take a few questions for the panelists at the end of the presentations. Those should be written into the chat function, so feel free to do so as the speakers go on. But from here, I'm going to hand it over to Claire to get us going. Thanks, Claire.
Thank you, Mark, for that introduction. And thank you so much, Deb, for sharing your story. I'm going to go ahead and share my screen now. I have a few slides to share with you all today. Bear with me. All right. Can everybody see that? Thumbs up? Great, thank you. So as Mark said, I'm going to be sharing some information about the substance use landscape in Massachusetts today. This is part one of a 3-part webinar series that we're going to be putting on. And we want most of the webinar series to be very solutions oriented. But before we really dive into the solutions, we want to make sure that everybody has the same understanding of the substance use context in Massachusetts. I'm going to be sharing a lot of data and graphs, but I want to urge everybody to keep in mind that all of these data points represent individuals, and please bring the dignity and empathy that they deserve to the conversation today. So in Massachusetts, approximately 9% of the population over the age of 12 has a substance use disorder. This is according to a national survey that was conducted in 2019. We know that the pandemic has really exacerbated substance use disorder across the country, so I would not be surprised if that number has increased since then. According to the federal definition, substance use disorders occur when the recurrent use of alcohol or drugs cause clinically significant impairments, including health problems, disability, and failure to meet major responsibilities at work, school, or home. Substance use applies both to legal and illegal substances. On the legal side, that's things like alcohol, marijuana in Massachusetts, and misuse of prescription drugs. And on the illicit side, that includes things like fentanyl and cocaine, among others. These graphs are using data from that same national survey that was conducted in 2019. And so I think, as I mentioned, these numbers may have changed quite drastically due to the pandemic. So I just wanted to draw your attention to some trends that they show. First, Massachusetts reports a higher prevalence of alcohol and drug use disorder than the rest of the United States. In addition, more adults have an alcohol use disorder than an illicit drug use disorder in Massachusetts. And I also wanted to note that because this data is from a federal survey, illicit drug use disorder is including marijuana, although it's legal here. There are a lot of reasons why people initiate and continue to use substances, which can lead to a substance use disorder. Those reasons can fall along the spectrum of individual, relationship, community, and societal level factors. On the individual and relationship side of things like poor mental health, stress, a peer group that's using, a family history of use, can all contribute to someone starting to use substances. But there are a lot of community and societal level factors that are influencing that individual's behavior. For example, if somebody is living in a neighborhood that is rapidly gentrifying and they're having trouble meeting rent, they might feel stress and start using as a coping mechanism. Historically, the United States has taken more of a criminal justice approach to substance use disorder than a public health approach. Starting in the 70s with the war on drug era policies, people who use substances were criminalized, and people of color were unjustly targeted in particular. That did not curb substance use, and we really learned from that a public health issue like substance use disorder really requires a public health response. With that context in mind, I'm now going to transition to talking a little bit more about opioids in particular in Massachusetts. So as you can see here, opioid-related overdose deaths have increased quite dramatically over the past 20 or so years. Even between 2020 and 2021, overdose deaths increased by 9%. Luckily, it does seem like that number is declining between 2021 and 2022, but it is a little too early to say definitively. When we talk about the opioid epidemic, people talk about it in terms of waves. So the first wave was caused by overprescription and illegal distribution of prescription opioids. That gave rise to heroin use, and now fentanyl is the most common opioid being used that's leading to overdose deaths. Fentanyl is around 50 times as potent as heroin, which really dramatically has led to fatal overdoses. There are also many other synthetic opioids out there. A lot of people are now saying that we're in the fourth wave of the epidemic, which is a polysubstance use wave. That means people are using multiple substances at once, a lot of the times unknowingly, and I'll talk a little bit more about that later. Overdose deaths disproportionately involve men in Massachusetts. They represent around 70% of all deaths. And overdoses really cause premature mortality. When you look at the 25 to 44 age group, they represent 5% of all deaths in Mass, but 50% of opioid-related deaths. And similar trend is true for the under 25 and the 45 to 64 age group. This graph shows overdose death rates by race and Hispanic ethnicity. You can see on the left-hand side that the death rate among the white non-Hispanic population has remained relatively stable over the past 6 or so years. It's increased pretty dramatically among the Black non-Hispanic population and Hispanic population. On the right-hand side, you can see that the American Indian non-Hispanic population has the highest overdose death rate, which is largely driven by their smaller population size. There are some real racial and ethnic inequities in terms of who is accessing life-saving treatment and harm reduction services. This is caused by lack of access, affordability, stigma, among many other factors. When you look at the map of the state, the central and eastern part of the state is experiencing the most overdose deaths, with Middlesex County experiencing the highest number. But then when you look at it per capita, the western part of the state and also Bristol County have the highest opioid-related overdose deaths per capita. This really shows that this is an issue affecting the entire state. And as I mentioned before, polysubstance use, not just opioid use, is leading to overdose deaths. So this graph represents which drugs were present in toxicology reports. Fentanyl was present in 93% of all toxicology reports with opioid-related deaths. I think it's really telling, though, that cocaine was present in 53% of opioid-related deaths in 2021. This is extremely telling because it's showing that people may be using cocaine and unknowingly it's been laced with fentanyl. If somebody isn't using fentanyl test strips, they may take fentanyl because it's been laced in their cocaine supply. In addition, alcohol and benzodiazepines are present in around 30% of the toxicology reports, and those drugs and alcohol can have really fatal interactions with opioids. Now I'm going to transition to talking a little bit more about youth. When we think about substance use prevention, it's really important to think about the youth population because if somebody starts using substances as a youth, they are at higher risk of developing a substance use disorder as an adult. So according to a Massachusetts survey that's conducted every 2 years, around 1 in 5 high schoolers report using alcohol or marijuana. You can see that these numbers have been declining over the past 6 years or so, and there was a pretty marked decline between 2019 and 2021. That's likely due to reasons related to the pandemic, so I'd be interested in seeing how those numbers change between 2021 and 2023. I also wanted to note that LGBTQ students report higher alcohol use and marijuana use than their straight counterparts. This is a trend that's mirrored nationally and likely due to factors that are unique to the LGBTQ population, such as bullying, harassment, and family rejection. So thinking a little bit more about opioids in particular, teens and young adults, as Deb mentioned, are using social media to purchase substances. And in particular, they're using it a lot to purchase pills like Percocets, Xanax, Vicodin, and Adderall. However, what they are purchasing might be a counterfeit pill. And as you can see on the picture to the right from the DEA, the authentic and the fake pills look extremely similar. In the United States, 4 in every 10 counterfeit pills contain fentanyl, which is really leading to overdoses. While social media sites are trying to crack down and regulate the drug deals on their sites, it has proven a little bit difficult to do. For example, if a social media site kicks a drug dealer off their site, they might just move to a different platform. And in addition, the search terms that youth and dealers are using are constantly evolving. I wanted to share this national study because I think it has implications for Massachusetts as well. It shows that between 2019 and 2021, overdose deaths between 10 to 19-year-olds increased by 109%. The majority of those deaths involved fentanyl, and nearly 1 in 4 deaths included evidence of counterfeit pills. 2 in 3 cases had a potential bystander present. Most of these overdoses happened within the home, and a family member was present. They just didn't know that their sibling or child was using. And approximately 40% of individuals had a history of a mental health condition. I think that this study is really telling because it shows multiple places of intervention for public health professionals. First, there can be things like educational campaigns for youth about purchasing pills on social media sites. In addition, public health professionals can educate family members about the warning signs of a child or sibling using and teach family members about how to administer naloxone, which is a life-saving drug. And of course, it's extremely important to connect youth who are using to mental health treatment. So I'll touch briefly on the continuum of interventions. First, there's the prevention side of things, which I have already mentioned a little bit. That's things like substance use education for youth. That's also things like creating strong family bonds between child and family members. Currently, I'm working with the city of Gloucester to work on a substance use prevention program, and kids have said that participating in sports has been really great protective factor for them not using substances. In addition, there's the early intervention side of things. For example, a primary care physician can screen for substance use in their office, and if somebody tests or screens positively, they can be referred to counseling. There's also a lot of treatment options. For example, there's medication for opioid use disorder, as well as alcohol use disorder, and many different behavioral health interventions. Finally, there's a lot of wonderful harm reduction strategies that include fentanyl test strips, syringe service programs, distribution of naloxone, distribution of safer smoking kits, and many, many others. So I wanted to end with just a few key takeaways. First, alcohol use disorder is the most prevalent form of SUD among Massachusetts adults. In addition, it's polysubstance use, not just opioid use, that's driving overdoses among youth and adults. A lot of that is being driven by cocaine that is laced with fentanyl. There are lots of racial and ethnic inequities in Massachusetts in terms of who's accessing life-saving services, but there are many, many effective interventions, which our panelists will be speaking a little bit more about today. I wanted to end on the popular harm reduction refrain, nothing about us without us. I could show you many more graphs and share more data about substance use disorder, but it's actually really important to center the voices of people with lived experiences when creating substance use programming. They will have the most expertise in this area. So with that, I thank you and feel free to reach out to me at my email address with any questions you may have. I'm now going to stop sharing my screen and pass it over to Andy Robinson. Thanks.
All right, great. Thank you so much, Claire. Let me see. I need to start sharing my screen here. All right, folks, everybody see that okay? Great. So again, my name is Andy Robinson. I'm from the Bureau of Substance Addiction Services, BSAS at the Department of Public Health. I work in the prevention unit there. Jose Morales, our director, was supposed to be here today, and unfortunately is not feeling well. So I'm standing in, and I'm gonna do my best. Within BSAS prevention, right? And I think I'd be remiss if I don't take a second to kind of reorient a little bit, right? Within prevention, prevention is a part of that spectrum that was shared, right? Prevention, intervention, harm reduction, treatment, and recovery services. And on the prevention side of things, we're really thinking about this idea of helping people before they're sick, right? Before they're not well, before, promoting wellness instead of intervening around sickness. And so just kind of, that's a difficult orientation given what we've already heard a little bit of today, right? There's no shortage of need. There's clearly a lot of people who are struggling in all various kinds of ways with substance use along that spectrum. And the resources, time, and attention we're putting into those spaces is important and necessary. But there's also this space, right, where we have an opportunity to promote health, where we don't have to wait for people to get sick to provide them something that can help help them support and maintain a healthy lifestyle. And that's really kind of where prevention is and comes in. And so that's kind of the space that I hope to kind of speak from today a little bit. And so we think of substance use prevention like a house, right? And it's something that our entire community is working to construct, right? So it's not about any one person, right? It's about the strong and lasting foundation of health and well-being for Massachusetts. And we use kind of these practices of prevention and prevention science to proactively kind of create shelter, right? That people can turn to, and that can kind of be built in communities. We use the public health approach, right? I heard a couple people mention that already, right? That substance use is a health issue, and it deserves a health-minded and health-centered approach. And we promote and support healthy decisions, right? Not good decisions or bad decisions, right? But really, we're promoting and supporting health. And in particular, within the prevention unit at BSAS, we're doing that amongst youth. And so youth, their families, their caretakers, adult mentors, and all the spaces within communities where youth live, work, play. We are looking to kind of, through our funding and through our grant support, enhance local prevention infrastructure. And again, we're looking to build kind of culture and infrastructure that supports healthy decision making around substances. and we do that through guidance, support, technical assistance for all those who receive our funding. We embrace and approach our work using a comprehensive prevention planning model. Our model, the one that we embrace specifically, is called the SPF, Strategic Prevention Framework. It's an evidence-based model that was developed by SAMHSA. But there are a number of evidence-based models that are similar that communities have used with great success as well. And really that model is about kind of how we kind of step back, we assess the need, we put together a plan, we implement, we evaluate, and then we kind of iterate over time. And so this is kind of just a visual of that model. And again, I think I see a lot of familiar faces and names on this call, and anybody who's worked with us here in the prevention unit is familiar with this model. It's a model that works for prevention, but it's really a model that works for any kind of public health planning that you're looking to address, substance use or otherwise. We take a very strength-based and asset-based approach. We set a relationship, that nothing about us without us kind of concept is one that is really important to us. That SPIF model is centered around a multi-sector model, right? And so it kind of takes every member of the community and all sectors of the community to come together and really approach prevention comprehensively to make the impact that we're seeking. And so relationships are a key component of that. And we look to be responsive to community need and kind of restorative in nature. It's been mentioned a couple of times, right? There is significant disparity in the way that substance use has been managed within the United States, in particular, these last 30 or 40 years. And so there's a need not just to fix and solve problems moving forward, but to acknowledge the damage that's been done and seek to restore those relationships and respond to the disproportionate damage that some people have experienced as the result of sometimes well-intended prevention and other substance use work. We seek to be data informed. We seek to be culturally responsive. We use and embrace evidence, and we look for sustainability. So what are the ways in which we can build our programs that they'll be sustainable over time? In Massachusetts, we have a lot of existing funding. Our primary prevention grant is called the Massachusetts Collaborative for Action, Leadership, and Learning, MassCall 3. This is a third iteration of MassCall for us. And we have three parts to that grant. Part A is a capacity building grant. We have 5 communities who are in receipt of capacity building funds, really just kind of building those basic coalition multi-sector structures, understanding and embracing that kind of planning process. And starting to work on kind of coalescing the data that's necessary to do a really good assessment. We have Part B communities. We have 33 of those communities across Massachusetts. Those are communities are organized in clusters, and so while there's 33 direct municipal recipients of our Part B grant, those grants touch over 200 communities because each lead is connected to a cluster of contiguous communities. And then we have a small group of Part C grantees, which are really pursuing innovation around prevention and intervention. And those are multi-year grants that are allowing for folks to think about real community need and innovations that are necessary to address that need over time. Then we have our state opioid response prevention and early childhood grants, state opioid response SOR, prevention and early childhood PEC. We have 15 of those grantees across the state. They're single community grantees, and they're really looking to work with young children and their families. We're thinking about birth, prenatal even, to about age 11 in those spaces. And we're thinking about youth who are at disproportionate risk for future substance use related to like exposure to substance use in their childhood environment in relationship to those grants. And so those that have been impacted by maybe the opioid epidemic or by environmental factors having to do with substance use that put them at disproportionate risk for later use. We also have a set of grants called Overdose Data to Action. Those grants are more harm reduction minded. We have 20 communities working on those grants. That's CDC funding. Those grants are really aimed at kind of some of the things that have already been talked about, naloxone training, recovery supports, recovery-friendly workplaces, any number of things looking to support kind of intervention and health related to those who are already struggling with opioid use disorder in particular. And then we have an assessment and planning grant called SPIF-RX, Strategic Prevention Framework for Prescription Drugs. That's a SAMHSA grant, Substance Abuse Mental Health Services Administration. And right now that is entirely a planning grant. And so SAMHSA has asked us to take a look at the kind of the groundwork in what prescription drug use looks like in Massachusetts right now, and what kind of needs are there, and how to plan to meet those needs over time. We also have a number of special projects. We work with the MIAA, which is all the high school athletics across the state. We have a great relationship with the YMCA and Boys and Girls Clubs across the state. We're working with an organization called Artist Communications on some great web-based tools. We continue to offer life skills training, support the Mass Clearinghouse, which is a place where you can get a lot of information to distribute to communities, educational information around resources and other things. We have some great pilots happening with the Department of Elementary and Secondary Education right now, as well as partnerships within our Native and Indigenous communities across the state. Again, we have a total through that kind of summary of 76 grant-funded programs, but again, those grant-funded programs touch in some way 200 of the 351 unique municipalities in the state. And so I know many of you, whether you're aware of it or not, have some aspect of prevention funding in your community, but there is still much for us to do to meet the needs of the entire state. We also support particularly our grantees using a number of consultants and outside entities. And so all of our BSAS funded grantees receive kind of intensive technical assistance supports from our partners at EDC. The Center for Strategic Prevention Support Services there has staff that reach out and work with communities directly to support them in some of the planning processes and evidence-based processes that I just kind of walked folks through. And then we have evaluation support services. Those services are provided in part by an agency called Social Science Research and Evaluation, SSRE. They're a great agency that supports a lot of different work throughout Massachusetts, but they really help keep us honest, and they help us think about how effective we're being over time in relationship to all these efforts, and we're really appreciative for the support that they provide. When we think about all the ways in which we seek to address prevention and prevention-minded work within Massachusetts, often people's minds go to this idea of programs, right? Curriculum, speakers, and programs. But there are a number of ways that we can effectively implement prevention. And among them is like environmental strategies, right? So thinking about policy and practice change at the environmental level, at the school level, at the municipal level, at the state level, at agency levels. How can we, instead of changing people one at a time or convincing people one at a time to make healthier choices around substance use, how can we create the environments that promote health, that make health the healthy choice the easiest choice for people to make? We also talk about prevention education, right? And that comes virtually, that comes physically, that comes by virtue of campaigns and promotions, classroom and other opportunities, information dissemination and communications, and then the community-based process that we encourage our communities to engage in and try to support through our funding. There are a lot of examples and samples for the purposes of time today. Again, I'll remind folks that everybody's going to get these slides. So I'm not going to spend a lot of time on each of these, but there are just a number of different examples here about the kinds of policies, practice changes that a lot of our communities have implemented over time that we found that have been found to be effective, not just here in Massachusetts, but across the country. And so, we think about commercial access, right? We think about regulation and ordinance and policy developments. And again, at all levels, right? School, community, state, municipal. And then we think about like the idea of social access, right? Which is access through friends and family, and other spaces. There are a number of evidence-based curricula out there. This is just a sample of a few. There are also a number of kind of workshop type models that support parents and caregivers and others that have been found to be effective over time as well. And then, both this kind of idea of campaigns and marketing, right? We think about social marketing, right? So social marketing is kind of selling health, right? And then we think about social norming, and social norming is really, in the simplest terms, this idea of like promoting the kind of the positive social norms that exist, right? And so when we look at this data, we see that maybe 30% of kids are experimenting with alcohol in some way, right? But that means 70% of kids are not, right? Which is the vast majority of kids. And so we think about how do we get those messages out there that most kids are not using substances, because we know that some of the 30% who are using are influenced by the idea that most of their peers are using as well, when in fact that's just not true. And so when we think about marketing social norms, that's the kinds of approaches that we're looking to take, is how do we promote and build understanding and awareness of the largely positive norms out there that exist relative to substance use, in particular amongst youth and their peers. And then, we build coalition capacity. And so how do we make sure that coalitions are inclusive and welcoming? How do we make sure that they're representative of the communities that they're intending to serve? And how do we make sure that they're using evidence-based practices in both of their planning and execution of strategies and their evaluation of strategies over time? Massachusetts also has a certified prevention specialist certification in place. And so those that receive our funding are encouraged to pursue that certification. I'm a certified prevention specialist myself, and it's a national certification that Massachusetts adopted many years ago. I think some of these things have already been mentioned by some of the previous presenters, but I think considerations for communities that are on this call, it's important to recognize, right, that in particular in relationship to youth, substance use has been trending down and continues to trend down and has been for some time. We're on about a 20-year positive trend in relationship to youth substance use, and I think that's something that's easily lost amongst the current climate of the opioid crisis, right? It's a real crisis, right? But largely, youth are making healthier decisions at a population level now than they have at any point in recent history, and that's something that I think we have an opportunity to build off of in communities, and it's important for us to understand. That prevention is a science, right? And so intent to do good is a really valuable thing, right? But wanting to do good isn't the same as embracing effective strategies to do good. And so it's important to kind of marry that desire to have an impact relative to youth health with the science of effective strategies that can accomplish those goals. Also, remembering, right, when we're talking about prevention, we're playing the long game. We're thinking about population level changes. There are a lot of things in relationship to the way we address substance use that are acute and really need immediate and urgent response. When we think about prevention, we're thinking about change over time. And so it's important within the prevention spaces to understand and kind of embrace and approach it in that way. We believe and know and honor that the most effective decisions are always guided by data. Data equals qualitative data equals quantitative data and equals the lived experience of those in our communities. And so it's important to honor and hold and maintain that. And then again, we're looking to engage diverse groups of relevant stakeholders in decision making. Make sure, in particular, that those who are seeking to affect and impact are at the table and informing and making and given the opportunity to make decisions about the things that will impact them. We encourage strength-based approaches, particularly relative to prevention, right? So, you know, thinking about the language that we use, the frames that we use to build the case for prevention and to implement prevention-minded activities. We're seeking to affect environments in a way that makes the healthy choice the easy choice. I said that already, but I don't think it can be said enough, right? How do we make it easy to choose health? It's a really important thing. And the language we use is important, and you know, hopefully I've modeled that throughout, but I think it's easy to get kind of sucked into that space of right, the difference between the language of legal and illegal versus good and bad, right? And so there are things that are illegal and illegal for youth to do, and there are things that are healthy and unhealthy for youth to do. But really thinking about how do we embrace and use person first language and language that kind of doesn't stigmatize is a really important part of this work, whether you're doing prevention or anything else along the spectrum. Always consider your audience, right? The messages we're going to send to youth are different than the messages we're going to send to their parents, and are different than the messages we may send to other safe and trusting adults or caregivers or agencies or organizations or businesses or entities. So always consider your audience and the appropriateness and benefit of your message for the specific audience that you're addressing. The idea that something is better than nothing isn't always true, particularly in relationship to prevention, but I think in relationship to other spaces, right? One-off events and piecemeal approaches may have a limited short-term impact, but right, they're never going to make the kinds of long-term systematic changes that I think we're all seeking in relationship to this work. And so I think it's really important to kind of step back and think about, you know, what is the need I'm trying to address? Who am I trying to address it with? And what is the change that I hope to create before we just act? I think often the first question is, well, what are we going to do? As opposed to like, what is the need we're trying to address? And what is our capacity to change that need over time? And what kind of changes are we seeking as a result? Our prevention work, particularly right in this idea of primary prevention, does not have to be substance specific, right? And oftentimes it shouldn't be. If we're talking to elementary school kids, right, or early middle school kids, often we're just talking about the, you know, the principles of mindfulness and decision making and management of relationships and resiliency and other things, right? And then we're thinking about how we can support them in applying those lessons that they learn in elementary and middle school to substances or to relationships or to finances even, or other things as those challenges arise in their life, right? So we're really looking to get as far ahead of these issues as we can, kind of build foundational skills that can have application both for substances and for other difficult decisions around health and wellness that youth are going to face over the course of their life into adulthood. And so we don't always need to talk about marijuana. We don't always need to talk about alcohol. We don't always need to talk about opioids, particularly when we're talking about youth, to have a really positive impact in relationship to substances over time. And then, you know, I think it's important. There are strong feelings, right? Emotions, personal stories, perspectives around these issues that just kind of range the whole gambit, right? And so it's important to create spaces that allow for folks to share those things and allow for us to understand, right, the spaces and places that all the folks at the table are coming from. And then it's important to kind of take that collective experience and ground it in those things that we're trying to accomplish together, right? And tell a more complete story that can really inform decision making and community goals moving forward. And again, I mentioned it already, but good intentions aren't enough to yield good results. We really need to make sure that we're grounding ourselves in evidence, and we're really thinking about the impact we want to have, that we're monitoring our interventions over time, right? And we're understanding the impact, the difference between the impact we hope to have and the impact that we are having. And that can be supported by kind of establishing ourselves in, or grounding ourselves in well-established practices. You know, it was mentioned right at the open, right? The capacity across our state is really varied. We have municipalities and communities that have, you know, substantial funding, substantial staffing and resources. And then other communities, right, who are just starting to understand these needs in their community, and maybe even as they understand them, don't have the resources or capacity to address them in the ways that other communities do, right? And so think about kind of that, the capacity you have, and look for the opportunities within your community that are within your capacity. You know, if you kind of reach too far, you're going to burn and use the limited resources you have to little effect, right? And so we often talk about kind of this idea of like a Venn diagram that says, what is the need, right, in our community? And there's no shortage of need, and need is varied. What is the capacity of our community, and where is the readiness of our community, right? What are we ready to acknowledge and take on? And it's that space in the middle of kind of need, capacity, and readiness that is the space that really we should be kind of zeroing in on in relationship to how we might prioritize the limited resources and capacity that we have to make a difference and to have an impact. We really think about quality over quantity. And so sometimes, and historically, we've measured things by how much we do versus how well we do what we do, no matter what we do, right? And so kind of depth over breadth. And then you know, if you're going to embrace and use evidence, right, we want to have fidelity to kind of the intervention strategies that we're pursuing, both in kind of grounding ourselves in the original need that we chose, that we kind of identified that we wanted to meet, the populations that we committed to trying to impact, and in relationship to the actual implementation of the strategy itself and the measurement of impact over time. And so it's hard for us to say if something worked the way we intended if we don't hold true to some of those fidelity standards that we set out with at the outset. And as much as we focus on what we're doing or the need to do something, why you're doing something, who you're doing it with, and how you're affecting change over time are really, for us, kind of the core components. What you do matters little, right? If you don't have a good understanding about why you're doing it, who you're trying to do it with, and kind of tracking and monitoring the changes and effects you're having over time. And so you know, that's for us what those evidence-based frameworks really support, and that's why they're so important to us in what we do. And then here are just kind of all the different ways in which you can connect with DPH. I'll make sure that my contact info and my director's info, Jose Morales, is on this and available to you all as it's shared, so that you can reach out to us. We you know, we support the communities that we fund, but we're here and available to support any community with questions or needs, or information that they might need at any point in time. And so please don't hesitate to reach out and to connect with us. If we don't know the answer, chances are good we can find somebody who is able to help. And so I really appreciate the time and opportunity, and appreciate you all being here today. And so thanks very much. And I think we'll stop sharing.
Yeah, thank you, Andy. We'll move to Dr. Bagley's presentation from here.
Great, thanks.
Awesome. Good morning, everyone. You can hear me okay? Okay. So So thanks so much for having me this morning. Andy, that was awesome to sort of have. I'm like really grateful for the order that we're doing this, because in terms of Claire being able to provide that sort of background in terms of the snapshot of what's going on with the state in the state. And then Andy, so much of what you said sort of resonated to some of the, like the themes around stigma and the importance of evidence, and also just like inclusivity is just you know, runs throughout hopefully what I'm going to talk about too. And finally, just like a huge thanks to Deb, who I've gotten to know over the last couple of years, for her advocacy and support of some of the research I did, full sort of disclosure, and just like her continued voice and sort of advocating for youth and access to also evidence-based treatment and more research to inform the work that we're trying to do. So to sort of close us out, I'm going to talk about practical solutions to address substance use, which is sort of a big topic. So I'm going to really provide an overview. And I just want to tell you like a minute about sort of who I am and sort of coming to this, so that you sort of understand my perspective, because like the perspectives from where we're coming sort of influence like how we're going to talk about things. So, and we all have different identities with which we're like sort of showing up to share this information. So I am a woman, I am a mother and a wife. I have 3 little kids. I live in Newton. I'm also a physician. I do primary care. I take care of adolescents, young adults, and their families impacted by substance use. And I'm also someone who like has a family history of alcohol and substance use disorder too. And so like all of those things sort of influence me, I think, in my thinking, in terms of trying to figure out what are the right systems, or what are the systems that we need to do to deliver this care and improve wellness and health. Like that's the goal, I think. And just want to acknowledge too here that I recognize, and I sort of saw first post that there's tremendous expertise in the people who are like participating, which is awesome. So thank you all for being here, but also that everyone is also showing up with their own experiences in terms of their own lived experience as someone who uses drugs or who has family members who use drugs too. And just want to sort of acknowledge that is sort of part of the journey too, is hopefully bringing together sort of diverse groups. What I'm going to do is I'm going to talk a little bit more about language and just sort of call out the importance of really addressing stigma head on. I think as we think about wanting to address substance use in our communities, it just like has to remain front and center, because there is so much stigma both around substance use and even the treatment of substance use, specifically opioid use disorder, and then talk in some general terms about sort of treatment of teens and adults with substance use disorder, sort of really based in evidence-based approaches. So just this sort of note about stigma. So as I said, substance use disorders, and treatment of substance use disorder are all highly stigmatized. Just want to, as we're in the spirit of level setting, just want to make sure we're sort of on the same page in terms of what the definition of stigma is, and then the potential influence that it actually has on people. So stigma is a set of negative and unfair beliefs that a society or group of people have about a particular circumstance, quality, or person. And when a person with a substance use disorder experiences stigma, they're seen as less than because of their addiction. I want to highlight the people who have other potential identities based in like race and gender. There's this like intersectionality that it can exacerbate the impact of the substance use stigma too, and sort of worsen someone's ability to like access treatment and sort of how they're treated in their communities and families. There are 2 main factors that impact stigma. So there's this idea of perceived control that a person has over the condition. So this idea that they'd stop using drugs if they really wanted to, and perceived fault in acquiring the condition. My addiction is all my fault and I deserve what I get. And I think that's something I personally hear from a lot of the patients, the young patients who I see, is this idea that it's like their fault, and just the tremendous like blame that like self-blame and guilt that they feel. And I just, this stigma, it's dangerous. Like I just actually I want to say that it's dangerous and it impacts people's ability to like access care. And I've had patients who like will tell me about in healthcare systems. Like I am a physician, we're so guilty of this, like not providing welcoming environments for people to come and access care. And so it really discourages people from sort of being able to talk about what's going on. And so there are sort of thinking about different interventions and ways to approach stigma. There's a lot, and that's a sort of own talk, but I think certainly a place to start is what Andy was mentioning in terms of the language that we use and sort of how we talk about people. And that's something that I think, you know, sort of coming together with shared language and talking, you know, trying to avoid terms like clean and dirty and bad and good, because there's just, that's like, there's a subjective bent to that I think can worsen stigma. So, you know, I think over the last couple of decades, there's been a shift in thinking about substance use disorder and really trying to not think about it as something that someone should be blamed for or a moral failing. And has really been is now more commonly thought of as a chronic disease, which I think can be helpful. And I'm going to talk about also a couple of ways where I think it's actually really different than some of the other chronic diseases that we treat in medicine. So, you know, substance use disorders occur when the recurrent use of alcohol and or drugs causes clinically significant impairment, including health problems, disability, failure to meet major responsibilities at work, school, or home. And when I am yesterday I was in clinic, when I'm in clinic, I'm sort of using this frame to think about an assessment when I'm talking to someone about their substance use. Importantly, there are really effective interventions, just like the prevention interventions, like we want to use science. There are effective interventions that can prevent initiation, as Sandy talked about, but also the consequences of substance use and then treat substance use disorder as well. And we should be really encouraged by that. Like there is hope, and there are ways that we can offer both effective treatment. And then as Deb was talking about, and Claire was talking about, like harm reduction strategies too, that can also mitigate the potential harmful consequences of drug use. And this is just, you're going to have the slide. So this is just another slide in the way that the American Society of Addiction Medicine defines addiction. What I want to just highlight is that in so many ways, it's really helpful to think about this as a chronic disease, because we can think about sort of accessing treatment, having an assessment, being able to come up with a treatment plan, figuring out what services are right to offer to someone. And then on the other hand, I think there are these ways that substance use disorder are really different than when I'm treating diabetes, when I'm treating asthma. And that's because it really requires, I think, communities to be coming together to sort of figure out what the solutions are that are going to work for individual communities. And it's hard for me to think about other sort of like diseases or disorders that really require so many different sectors to come together to figure out what the right solutions are. It is the reason why I love doing this work, because you get to like meet so many amazing people, but who are passionate and trying to make a difference and affect substance use trajectories. But I just want to highlight that this is like, it is, as like a physician, I am totally dependent on the multidisciplinary team that I work with. Like there is just no way that like addiction medicine alone can sort of deal with substance use disorders. It really requires everyone coming together, from behavioral health, from schools, public health, really, and people, and people with lived experience sort of included and integrated, hopefully throughout that, to address substance use disorders. So I'm going to talk about a couple of different ways that we can think about our approach to thinking about to treatment. So first, I'm going to think about an overview of the kinds of treatments that are available for substance use disorder, evidence-based treatments, and then talk a little bit about the levels of care. And I'm going to highlight sort of how this is true for both youth and for adults. So the mainstay of a lot of treatment of substance use disorder are behavioral treatments that have been sort of shown through like decades of research to be really effective for treating substance use disorders. And they include specific interventions or treatments like cognitive behavioral therapy, which is also used for depression, for anxiety, relapse prevention, contingency management, which I think has gotten more funding recently, and I think has also been sort of in the popular press a little bit more recently too, but it's actually also been studied for like decades and been shown to be really an effective treatment, which is a way of providing someone really with like positive rewards for behaviors that they're trying to change. And then just wanted to highlight that motivational interviewing is a common guiding approach to a lot of these strategies. And finally, that treatment of co-occurring mental health disorders or behavioral health disorders can be integrated into treatment for substance use disorders, and that it's really important. I think that sort of, I often think about one of my colleagues who talks a lot about this idea that like behaviors make sense. And so when we think about someone who is using alcohol, is using drugs, may have a substance use disorder, that there is something that is like positive reinforcing. And for a lot of the patients I take care of, I'm thinking about patients I saw yesterday, they have underlying anxiety, there's underlying depression, there's underlying histories of trauma. And so using alcohol or using drugs really provides an escape from those symptoms. And so it is really then like our responsibility, like our sort of healthcare system, to think about, our communities to think about offering a like potent, effective treatment for those co-occurring mental health disorders. Because we need to sort of, how can we offer treatment in a way that is better than using alcohol or using a benzodiazepine to treat anxiety? Like we have to be able to offer treatment that is better than that for our patients. We also have medications to treat opioid use disorder, which I think probably a lot of you are familiar with. So there are 3 FDA approved medications: naltrexone, buprenorphine, and methadone. Only buprenorphine is approved for youth 16 years and older. Naltrexone often though is used off-label for adolescents, and then methadone in general, unless you're 18, is sort of difficult to access. Based on the evidence, and this is really sort of multiple studies done in the United States and abroad, it's very clear that methadone and buprenorphine are the most potent tools to prevent fatal overdose. And sort of going back to this idea of sort of thinking about the science and evidence, sort of if I have a patient who I'm treating who's had a cardiac event, has had a heart attack, has had a hospital stay related to diabetes, like I think that person, their family would be expecting us to be using medications that are going to like prevent recurrence of whatever that event was, and certainly trying to prevent death or mortality. And so I think that so sort of thinking about those medications is that I think about these as life-saving medications. But there's also a lot of stigma and a lot of reservations and ambivalence around these medications. And so I think understanding in communities sort of like what the feelings, how people are sort of perceiving these treatments is really important to figure out how they can really be integrated into different settings. This is just a table that you can sort of have for your reference. A lot of you, I probably know a little bit about this in terms of the different settings of where you can access. So methadone is only at opioid treatment programs that are federally qualified. It blocks effects of opioids, it reduces cravings. Buprenorphine, any sort of trained, you have to have specialty training, although that is going away. And outpatient settings can provide buprenorphine. It blocks the effects of opioids and reduces cravings. And naltrexone, anyone can prescribe, and it blocks the effects of opioids. And I think that I will say sometimes I think when people have had negative experiences with medications, what I've found sometimes is like the medication is sometimes seen as like the fault of the relapse. I think sort of understanding that there are a lot of things that can contribute to someone's relapse. And so it's important. It's just important to sort of have conversations, I think, with people about sort of what their reservations about medications might be if they exist, because they really are the best treatment that we have to prevent overdose at this point. Okay. That was alcohol. So we also have medications that we use to treat alcohol disorder, alcohol use disorder. These are the 3 FDA approved medications: naltrexone, acamprosane, disulfiram. We have other off-label options as well. These are all available through healthcare providers, although in general, there's been really sort of low uptake of a lot of these, to be honest, and they can all be used on their own or as an adjunct to behavioral health behavioral treatment as well. Similar with opioid use disorder, you can certainly, like, behavioral treatment can be, in addition, I would say there really has been a movement for people who are prescribing buprenorphine or using meth to not require behavioral treatment, because we really want to be able to sort of like provide that low barrier care and use that harm reduction approach to get people engaged. You've heard a little bit about harm reduction, which I think sort of is part of the continuum and is increasingly being integrated into treatment too, so that we can really think about it, sort of knowing that potentially lapse or relapse or continued use or ambivalence may happen, that there are always opportunities to try to reduce the risks of substance use. And so harm reduction with sort of small h, small r is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. They can include lots of different strategies, which you may be familiar with, like overdose education, distributing naloxone kits, providing sterile needles or other sterile works for people, safer smoking supplies, HIV prevention, like we have a medication that we can use to prevent HIV, drug checking programs, which also include things like fentanyl test strips. And there are also places across the state where you can actually go or send in the drugs that you use and then actually have it checked so that you can see what's in your supply. Because as we heard, there's a lot of contamination with fentanyl, but also with other things, other contaminants, and people really are eager to understand what is sort of going in their bodies. There is just lots of high quality evidence that these strategies reduce harms and save lives. And as I said, they can be integrated into treatment, and that a safer injecting equipment is a little bit more complicated it's complicated for under 18-year-olds, but sort of thinking about harm reduction in general and thinking about reducing risk for adolescents is also totally appropriate when I'm talking to my patients who are younger, who are using cannabis or alcohol or opioids. We are always offering the information or the advice that like no use is safest, or sort of thinking about abstinence as safest, like that is just going to be the safest thing. And then really wanting to provide opportunities for conversations about what they're going to do to keep themselves safe if they are using, because the worst thing that I can do, I sort of feel like the worst thing I can do is to sort of have that information about how I could keep them safer and not be able to offer it to them. We heard from Claire sort of early on that there was sort of in that recent data from the CDC a month ago in teen overdose, there was like very low response rates with naloxone. And so like it's on me to be having those conversations, on all of us to be having those conversations about how to prevent overdose. It is the third leading, drug overdose is the third leading cause of teen deaths in the United States. Motor vehicle crashes, firearm related injuries are the top two. And I would say like pediatricians, like we own those and say that we need to be intervening and making sure that we're keeping teens safe, and that we really need to have like that same urgency and use the same, use these evidence-based approaches to protect our teens and to offer them the information that they need. I'm just looking at the time to make sure we finish up. This is a slide that just sort of shows the continued. Now I'm going to sort of switch to we talked a little bit about the different kinds of like individual treatments that are available. I want to talk for just a minute about the different like levels of care that people may access. And this sort of shows this, that continuum of sort of thinking about early intervention to sort of medically manage intensive inpatient services. And along that, you sort of see there are outpatient services. We'll talk about that a little bit, IOPs or PHPs, and then residential or inpatient programming. So in general, I think like when patients or families ask us, they sort of say like, what's the right level of care? And in general, what I try to say is like the least restrictive environment is awesome. And like, that's really what we want to try to do and sort of keep people, if possible, like with their families and their communities, like in their environment, and that's really based though on safety and an assessment and sort of also like what an individual may want. So outpatient treatment is sort of that sort of least restrictive kind of care. I just want to sort of, and often is sort of maybe like weekly therapy or weekly visits with a physician. I just want to note that thinking about medication treatment, as you're sort of thinking as what communities be doing, you know, outpatient treatment can be initiated in emergency departments or in hospitals too. So as we think about this continuum of care, really sort of wanting to think about sort of how we make those linkages. So at BMC, I also spend a few weeks a year on our inpatient consult service. And so that means them taking care of adults who are admitted with like pneumonia, and they also inject drugs. And so we talk to them about starting buprenorphine, about starting Suboxone, and then we're able to start it in the hospital and link them to the community. Or if they're not wanting to stop using, sort of talk to them about harm reduction, make sure that they have access to primary care, other behavioral health services, if they want treatment for their anxiety, or like whatever they want, you know, like I'm not there to tell people what they want, but to be able to really link them to the services that they need. And so there are a lot of really innovative, cool things happening around thinking about how to offer these treatments in ways that are more accessible to people. Some people, you know, intensive outpatient programs, which is usually a few hours a week, a few days a week for a couple of weeks, and then partial hospitalizations are not overnight stays, but are like longer periods of time for a couple of weeks that just provide more support for people. Sometimes when they are starting out and just sort of need that, sometimes it's a step down from residential, but like, I don't know if it's like the continuum, it's like a circle, like people are in and out and needing different things at different times. And so I think it's what we have found, it's a constant reassessment of what people need, which also really highlights the importance of networks and strong connections so that we don't create silos as we think about these continuums or different levels of care. You really need strong connections so that people feel like they are not being discarded or sort of discharged without clear follow-up plans, like Deb was describing was happening to her daughter a lot. I'm in the interest of time just going to go ahead to the last couple of slides, but you'll have these describe sort of acute treatment services, which is also detox that's available in Massachusetts. We call it ATS, but just if you want some sort of more information about what might happen. And then this is typically for adults, especially what we hear is sort of going to detox, to a CSS, which is more of like a stabilization unit, and then to a transitional program and residential treatment. Like that is a pathway for some people. For youth, there is a BSAS funded or state funded sort of location in Worcester, MIR, Motivating Youth in Recovery, where they provide management of withdrawal and then sort of crisis stabilization. Usually kids are there for like 14 to 28 days. Just a couple of quick notes then before I end. Just one that is that, you know, the importance of engaging the family. You certainly heard Andy talk about the importance of thinking about family when we're talking about prevention. I think it is also just critical when we're talking about treatment too. Certainly for people who are over 18 and even under 18, so you're really getting consent and agreement to talk about families is necessary. But family members are often key players to successful treatment and not always explicitly involved in treatment planning. And there are really missed opportunities when we don't develop approaches to explicitly include them and make sure that they understand what treatment is. And also they know their child, they know their parent, they know their partner best. And so it's really critical that we, as we think about developing systems of care, we think about sort of really family-centered options. And then in addition, sort of treatment and support for family members when their family, when they need, because they need their own support as well. I talked a lot about sort of more medically focused approaches today. And just as I sort of started out with, it's more than that. And there are these really important sort of adjuncts to treatment, like mutual help groups for individuals and for family members. There are recovery supports that are increasingly being integrated, and the state is funding a lot of work in this space for positions like recovery coaches, peer recovery navigators, peer support, harm reductionists, harm reduction specialists that are really also critical because they sort of add this additional layer of helping us to provide comprehensive, holistic, sort of really responsive care for people who are impacted by substance use. So sort of trying to bring it all together. We have improved access to services for individuals with substance use disorder. And we really need to think about how we do a better job of bringing more of these services to communities. We're fortunate to be in Massachusetts, where a lot of work is funded and a lot of programs are funded, and there's more work to be done. And as I said, there are a lot of evidence-based strategies that are out there, and we just need to continue to identify and implement them in ways that they are connected and sort of not siloed from each other. I think as we do that, I think one call for all of us is to think about how to tailor or sort of center. I really like that, Andy, centering services for all individuals, because there is a history of discrimination and racism and sexism that has really impacted the impact of substance use and access to substance use care for people in Massachusetts and in the rest of the United States. And so ensuring that programs are responsive to people's needs is really critical. And if you don't do that, there's a risk of really exacerbating inequities as well. Okay, here are some resources that you'll have, and then just a slide about how to find naloxone in Massachusetts as well, which is always important to be able to share. I'm going to stop. And my email's in the beginning, and be happy to sort of talk to anyone if there are more questions too.
Well, yeah, thank you so much to all our speakers, to Claire, to Andy, and to Dr. Bagley for those really helpful presentations. Yeah, we will be collating the slides and providing them to participants. If you also had further questions we weren't able to get to, the chat, raised some, both myself and Claire Hoffman from MAPC, we put our emails in the chat, and you can definitely reach out to follow up. And with the slide information, you'll also have the contact information for our speakers, so you will be able to contact them as well after this. But yeah, I mean, as we mentioned before, this is the first of a 3-part series, so we're going to have 2 further sessions. The next one we planned for Wednesday, February 8th, also at 9:30. That's going to focus on shared challenges and best practices. And the final session will be on Wednesday, March 8th at 9:30. And there we're going to talk about solutions and funding and kind of some of the things we can do together, based on our conversation. So really appreciate your time, everyone. Thank you to all the speakers. Thanks for all the participants. Thank you to Deb for getting us rolling on this and engaging us on this topic. And we look forward to see you all in February. All the best.